Awesome. Thank you, Jody. And I'd like to thank the AAO for having us here and allowing us to do this session here on 3D digital orthodontics. We're going to spend quite a bit of time discussing CBCT technology and how that technology has really changed the way I practice orthodontics. So the title for today is 3D Technology Changes Everything, 3D Digital Orthodontics. A little bit about me. I'm board certified, member of all the organizations that you need to be a member of, key opinion leader for Plan Mecca. I'm on the advisory board for OrthoScience and Form Labs. In my previous life, I was an assistant professor of management and marketing before meeting an orthodontist that convinced me that I should go to dental school. So I went to dental school at the University of Louisville, residency at NYU, and then been in private practice in Nashville, Tennessee. I've got 4 fish, 3 kids, 1 dog, 1 lizard, and my beautiful wife, Sarah. And without further ado, let's get going. So today, what we're going to talk about are the benefits of 3D in orthodontics. We're going to look at differentiation and how using 3D technology can help with that. Specifically, we're going to talk about ultralowdose and its value to orthodontics. And then we're going to do a little bit of time with anatomy and not analysis. And for those of you that were fortunate enough to hear Dr. Jack Fisher's presentation yesterday, he and I are very much on the same page regarding anatomy and not analysis. And then a little bit of time there at the end discussing how we can use this technology to continually improve as a clinician. So when I first adopted CBCT technology in the practice, I got it primarily for diagnostic purposes. But it wasn't too long after that point that I realized one of the biggest benefits that probably doesn't get talked about a whole lot on the lecture circuit is the benefit of education as it relates to patient interaction. We're used to looking at 2D pans, 2D Seths, but patients aren't. And they live in a 3D world, even though a lot of orthodontists live in a 2D world. The ability to then explain what you're planning on doing using a rendered 3D rendering of the patient really allows greater opportunity for explaining what it is that you're doing. So that is one benefit that I had not intended on getting, but just kind of happenstance got. So when I think of benefits of CBCT and what they are for my practice and myself, really it allows me the ability to properly diagnose and treatment plan a case. And that in large part centers around the alveolar boundaries or the alveolar housing that the teeth sit in. They're really what dictates my treatment plan, what determines what it is I can do on the case, what mechanics I can use or not use. And it really becomes down to more about anatomy and not so much about analysis. So no longer am I looking at various analyses. Now I'm looking at the patient's individualized anatomy and personalizing treatment to their anatomy, not to norms that we're used to looking at. There's also no more guessing. So many times we would look at a 2D pan or a 2D Seth and I'd be like, well, I think this, or I think that, or I think that impacted canines here. Now I know what it is that I'm looking at. Also, it's much less likely to miss something when you're looking at it in 3D, all 3 planes of space, than you are when you're just looking at a 2D pan or Seth. And at the end of the day, let's say you take away all of the ones at the top, the proper diagnostic and treatment planning, alveolar housing, anatomy not analysis, and you're just left with lower radiation than 2D and more information than 2D. So if for no other reason than those 2 reasons, we as a specialty should adopt this technology. And I don't know that I'm capable of saying it any stronger than that. It is our responsibility as clinicians and as orthodontists, as specialists, to practice at the highest standard of care, not at just the standard of care. And that really comes down to being able to diagnose and treatment plan properly. And at the end of the day, when you consider that it's less radiation than 2D radiography, and the amount of information you get is significantly more than 2D, it really is a no-brainer. So let's look at a case real quick. This is a patient that presented to the office a few years ago. And, I'm looking at the pan and I'm saying there's not a whole lot that's remarkable about it. The condyles, for what you can tell, they look pretty good. There's, no apparent pathology. The upper left central looks a little bit short, but that's really about it when it comes to this pan. And here are her photos. This is kind of a straightforward case. When it comes into your practice, you're thinking, man, I don't even need a Seth. Do I really even need a pan? And in some of the Facebook groups I'm a part of, I see a lot of discussion about, oh, do we even need a Seth for this case? Oh, do we even need a pan? Well, in this case, I already had a pan. What would be the benefit of taking additional records on this case? I would have a lot of orthodontists say to me, oh, you don't need additional records on a case like this. I mean, it's really just very, very mild crowding, and not a whole lot of necessity, certainly for 3D in this case. But that's not how I want to practice. And so part of my standard protocol is CBCT on every patient. And in doing so, this is the 3D rendered pan. So there's not a whole lot of information that changes much when it comes to that. Now, the patient also tells me during the clinical exam towards the end of it, oh, by the way, I'm also finishing up treatment with one of these DIY aligner companies. And, the main reason I'm here, as I mentioned, is my bite just doesn't feel right. Like, it just doesn't feel right. And I'm looking at her occlusion. I'm saying, well, your occlusion's not bad. But then I'm starting to say, okay, well, let's look at the CBCT, and this is the we call them bone builds, alveolar housing. Ultimately, what it shows is the alveolar boundaries or the limits within which I have to operate in order to keep the health of the patient my focus throughout treatment. And if we zoom in here, we can see just how much resorption has occurred on the upper left central. Now, I doubt very seriously that in-house aligner company, or not in-house aligner, the DIY aligner company caused that damage to the tooth. I don't think they helped it much because they essentially threw it into traumatic occlusion, which is why I think there's a widened PDL space. But they certainly didn't help the situation. And if you look there where the red arrows are, you can see in these slices how little bone there is on the facial surface of those teeth. So before starting treatment on any adult, I always make sure that they have periodontal clearance from their dentist or periodontist. And so this patient clearly shows up. I request that periodontal clearance and then send her to the periodontist to say, hey, what's, do we have, clearance to treat her case? And periodontist sends me a message back and says, oh, yeah, you're fine. I see some recession on adult cases all the time. You should be good. And so then I send her back this CBCT, and she does a better periodontal exam and actually finds some subgingival calculus. And this case was actually, I think the reason that there is such significant resorption on that tooth is because it was treated in the midst of periodontal disease. And unfortunately for the patient, I think they've got some concern there. She's since had a gingival graft and some other treatment done. But it's buyer beware when it really comes to these DIY companies that are operating in our healthcare arena. So here are the initial trays. So this is tray 1 from that aligner company. And you can see based upon that first tray just about how much crowding the patient had. And I think even if this case were to be treated by a GP, there are very few GPs that would treat this case without at least some interproximal reduction. But unfortunately, this patient didn't have that done. As a result, we can see just how much flaring occurred between where she currently is when she presents in my office and where she was when she started. What I did, I took a CBCT of her first tray, and then I superimposed that over where she was currently over the posterior teeth, because we know you don't have a lot of control over posterior teeth, especially without attachments. And so I think this probably gives us a pretty good idea of where things were when she started. And we can see there that the lower incisors were flared about 2.5 millimeters at the incisal edge. We can also see the amount of wear that had occurred and how that tooth has now been thrown into traumatic occlusion. And even at the CEJ, it was pushed forward about 1.5 millimeters or so. So in this case, I think we could have, or she could have prevented having harm done to her by this aligner company by, one, going to see an orthodontist, but more importantly, just having knowledge of what the bone levels are around teeth and knowing how to proceed in those cases. So we're in a case where I think a lot of orthodontists probably would have been fine with the pan, and maybe they would have gotten periodontal clearance. Certainly, 3D allowed us a greater opportunity to determine what needed to be done in this type of case. So another reason that 3D is beneficial from just a marketing perspective, I can't really tell you how to market during COVID, but I think 3D can be a differentiating factor for your practice. It can differentiate you from the GP that's doing ortho down the street, and certainly can differentiate you from DIY aligner companies out there. So when it comes to 3D technology, what 3D technology do we have in our practices? The most obvious and the one that we're most familiar with is study models. We've been using digital study models for, I don't know, going on decades now. Analysis and diagnostics, CBCT, 3D models, 3D photographs are even available now. The ability to do virtual treatment simulation, where you're integrating CBCT data and STL files. And then the ability to 3D print the models for in-house aligners is also another huge opportunity. And it's something that we can do from an appliance standpoint. Also indirect bonding, appliance design. So much has changed even in the last 2 to 3 years with regard to what we can do using 3D technology in our practices. Implant planning or TAD planning is also a great benefit. And then orthodontic surgical planning. And we're all familiar with medical modeling, I think, at this point. So a whole lot of application for this technology. And where do I find the most practical application when it comes to intraoral scanning technology? And that would be really in the realm of aligners. And about, I'd say 3 or 4 years ago, I basically went all in with in-house aligners due to frustration with several of the aligner companies out there. And it was just taking too much time to go back and forth with lab techs that seemingly didn't know what they were doing. And then I was using the tools to move the teeth myself. And I thought, if I'm having to do all this work, I just need to bring it in-house. And so that was my transition from outsourcing my aligners to bringing those aligners in-house. Other benefits of using intraoral scanning would be saved appointments on appliances, ability to have study models and digital storage of those, the virtual, doing a virtual setup so you can virtually walk through the case prior to treating the case in the office, diagnostic and treatment planning options, and you being able to show those to the patient all starts with that intraoral scan. And then ultimately, and this is a big marketing, I call it a gimmick. I don't know how beneficial it is. I think a lot of orthodontists, at least where I practice, seem to have intraoral scanners in their practices, but you can market being an impressionless office. I am quite active when it comes to 3D printing. I've got 4 Formlabs printers, and they are great printer. I primarily use them for aligners, dabbling in some indirect bonding with them. You can do implant guides for GPs. I've done a few of those, and then orthodontic surgical splints as well. So the biggest area for 3D, or the way that I use 3D most in my practice, is with CBCT. And when I talk to other doctors about CBCT technology and how I use it, I've kind of, over the years, gotten a list of some of the pushback. And so I like to hit that pushback, and hopefully it will answer some of the questions that you may have. The first question, or the first pushback that I used to get, and this is as of several years back, is I don't want to overrate my patients. And what I've found is, over the last couple years anyway, most doctors are at least aware now that ultra-low dose machines are available, and that they actually image patients at a lower dose than 2D radiography, even 2D digital radiography. So that's really become a non-issue. Number two, I don't know how to read or interpret a CBCT. I think that's probably one of the biggest and most valid concerns that orthodontists have. The third one, I don't want to be liable for all that information. You're liable for all that information regardless of whether you take a CBCT. I feel like I'm more likely to catch something using CBCT than I would have caught otherwise. And I'm going to be held to that standard of care if ever called to court. And I want all of the information that I can get at my disposal based on what I've been told, when I get there at some point in the future. We were told in one of our legal classes in residency, it's not a matter of will you be sued, it's a matter of when. And I think CBCT and the amount of information that I have before me allows me to do a better job with diagnostics. So you're going to be liable for the information, whether you want to be or not. And that's really whether you refer out to a radiologist or not as well. You're still responsible for the orthodontic component of the treatment. The fourth one, I can't afford a CBCT machine. I bought my CBCT machine probably 2 years out of residency. Owe a significant amount of money, both for dental school debt and for residency. So and not including practice, home, car, all of the other debt that we have. And if this poor indebted orthodontist can afford a CBCT machine because he feels like it's what's best for his patients, the doc out there that's been practicing 20, 25 years with several $1 million in the bank for retirement certainly can afford a CBCT machine. And then the fifth one, I just don't want to spend the extra time or money. And I would say that's a legitimate one. I don't like hearing that one because to me, it's got an element of laziness associated with it, which just kind of irks me a little bit. I don't consider orthodontists as lazy individuals. So when somebody tells me that, it kind of bothers me a little bit, which that really leaves the biggest issue, which is educational deficiencies, which is why I want to thank Plan Mecca for sponsoring events like this, CE events like this, because without this, I don't know that we would be able to educate ourselves to use this technology, because residency programs, though they are great in what information they're able to convey to students, they are not set up to teach CBCT, in large part due to we're dependent upon faculty that are either currently in practice and don't use CBCT, or we're dependent upon faculty that have, basically practiced for 25, 30 years. They're on the tail end of their career and they're just wanting to give back. And that's great. But to be able to do so using CBCT, they themselves will need to find educational opportunities. So I think there's a huge opportunity for companies like Plan Mecca and others to provide educational content related to CBCT and how orthodontists can use it to better treat their patients. And so I really think that a lot of this education regarding CBCT and how it can be used in orthodontics comes not from the traditional structure that we're used to education coming from, but rather CE opportunities like this one. So what really changed everything for me and pushed me to adopt this technology was ultra-low dose CBCT imaging. So without ultra-low dose, radiation exposure was, I would have said, potentially a legitimate argument against the use of CBCT in all cases. Even though you got, with the newer machines, more information and with less radiation, some of the older machines certainly were radiating patients at higher doses than 2D. The newer machines that are out there, most of the better companies have figured out how to do ultra-low dose imaging. And to some degree, it's a matter of settings. Just lower the MAs and lower the KVPs and lower the amount of time the patient's exposed. But the behind the scenes part of it is really the algorithms necessary to process all the images that are taken and combine them into a CBCT volume. So we're going to look at a couple of pieces of literature here to discuss some of that information. The first was the point and counterpoint AAO back in 2012. The point was that CBCT offered substantial advantages. It allowed us to measure more accurately, so forth and so on. The counterpoint was that the efficacy of the technology was lacking, that it was simply overkill, potentially leading to a public health problem, and that we should resist the lure of technology for technology's sake. And I think it was about that time that ultra-low dose technology came out. It wasn't too much before that the AAO released a position paper saying that we should use CBCT technology cautiously and that we should only use CBCT when it's justified clinically. Regarding radiation exposure and ultra-low dose protocol, what we have to remember as orthodontists that are going to be using this technology to treat our patients is that the diagnostic capability of the images must be kept at the forefront of the discussion. Because like I said, anybody can lower the radiation dose. What's important here are the algorithms behind the scene that build the volume and that filter out some of the unnecessary, not filter out the unnecessary information, but manipulate the data in a way that it turns what would have been an unusable image because of lack of KBP or lack of time or lack of MAs and turns it into a usable image. And the Planmaker Pro Max Mid, this was what machine was used for this research that Ludlow did in Koivisto. It was a combination between UNC and University of Helsinki. But they looked at, were they able to maintain high diagnostic quality imagery while lowering the radiation dose? And so the quote from the article is that radiation dose was able to be reduced without a loss of diagnostic quality. So they were able to lower radiation dose by as much as 77%, which is pretty remarkable, and then still maintain high diagnostic quality images. Other machines out there claim to be ultra-low dose or claim to image with less radiation. However, a lot of them don't have the back-end algorithms that are actually making the imagery usable. So this brings up a conversation of ALARA versus ALADA, and it's a publication regarding or specific to CBCT that we need to image according to our diagnostic needs. So in my office, what that means, initial records are usually taken at 600 microns, and that's a full field of view, and that dose is around 15 microsieverts. If I need to do a dental only, that resolution is at 400 microns, and which does give us a slight improvement in resolution, but because you've reduced the volume size, it's actually reduced the total amount of the total effective dose of radiation down to about 10 microsieverts. So this led to another article, which was in the Centennial edition of the AJODO, and it was the history of imaging in orthodontics from broadbent to cone beam computed tomography. And what the question I have for you, well, we'll get to that question in a minute, is what are the indications for 2D radiography in orthodontics? Let's hold that question just for a moment. And let's talk about what this article said, which was that evolution of a new technology took a significant turn. Several CBCT manufacturers with a combination of partial rotation, low settings, pulse technology, where radiation only happens when taking images, created a CBCT scanner that takes a 3D image with less radiation to the patient than a panoramic radiograph. And that's a panoramic radiograph, not a film pan, but a digital pan. And this resulted in the ideal, and again, this is a quote from the article, this isn't me. This resulted in the ideal combination of more information with less radiation, which by logic and historic perspective makes the choice obvious. When I saw this publication, I thought, it's done. This is now the standard of care for orthodontics. They have basically said in a nutshell what I've been saying for a few years now, and I thought, oh, this is amazing. This solves the issue. Everybody's going to adopt this technology. So let me tell you how I use CBCT in my office. Every patient is imaged using the ultra-low-dose, low-dose setting. I purposely don't have a 2D Seth arm on it because I can render a Seth from that 3D volume. I have the ability to take a 2D pan, but I don't. I actually ran the numbers the other day. I've taken thousands of CBCTs. I've taken less than 30 2D images on my machine. I think an important characteristic of a CBCT machine is that you need to be able to adjust the field of view, because that can then decrease the radiation, allows you to focus on specific areas, and most of the reputable companies out there have that capability on their machines. And I think ultra low dose is paramount given the patient demographics that we work with on a daily basis. So radiation exposure from CBCT is now less than that with traditional 2D radiography, whether you're talking film or digital, which means you basically get more information with less radiation. And so that thereby allows you to do some patient education as well as better discuss the case so that they can understand what the plans are regarding treatment. One other thing that Planmeca has done is come out with an algorithm called CALM. And what it does is it reduces the effect of patient movement on image quality. The number one reason that you are likely to have to retake a radiograph, and this is whether it's 2D or 3D, number one reason is because of patient movement. And so what they've been able to do is, using an algorithm, minimize the effect that patient movement has on the image quality or the volume that's then rendered. So what does this mean for me? It means that not only am I using less radiation than 2D, but that if I do have to retake an image because of, for whatever reason, I can do so knowing that it's unlikely that I'm having to retake it because of patient movement. It's something else. I'm wanting to image another area at a higher resolution, perhaps. It's rarely do I retake a CBCT because of patient movement, and it's because of this algorithm that's been developed. So I'm sure right now in the moderator questions, there's probably several on, oh, is it true that 2D is more radiation than 3D? Well, let's look at some of Ludlow's research that was published in the JADA in 2008. And it basically showed that a 2D pan was about somewhere between 15 and 25 microsieverts. And then from that point, it just goes higher the older that the machine is. And for my initial records, which I can derive all of the images that I want, pan, Seth, PA Seth, submental vertex, images just looking at the canine, basically any canines, or looking at alveolar boundaries, or a fully rendered skull, or basically any image I want to create from this volume, I can now do so. I'm not having to re-image the patient and re-expose them to additional radiation to get the information I need to properly diagnose and treatment plan the case. But I'll usually take records at 3 points. The first point is for initial records. That's about a 15 microsievert dose. For progress records, I'm usually doing a limited field of view dental only, and I'm looking at for bracket repositions or just determine kind of where things are going. That's about 10 microsieverts. And then for final records, doing another full field of view, that's about 15 microsieverts for a total dose of about 40 microsieverts. If you look at the average 2D dose for those 3 time points, you're looking at somewhere between 45 and 90 microsieverts. On the high end, over double of what my patient is receiving. And at that point with 2D, you don't have near the amount of information I have to treatment plan the case. So times are a-changing. And I would say given the higher radiation dose associated with 2D radiography, I can't justify its use in my practice. So is 2D radiography justified in orthodontics at this point? And I would say absolutely not. Most likely you have already depreciated your 2D machine anyway, and it's time to upgrade. It's just it's not a matter of will you upgrade or will you adopt 3D technology. Whether you want to adopt it or not, you're going to adopt it. And I think, if you're honest with yourself and somebody says, well, you're eventually going to have to adopt 3D technology in your practice, you're probably going to say, yeah, I know I am. I'm just not ready yet, whatever the reason is. But it's not a matter of if you will adopt it. It's just a matter of when that adoption will take place. And so now with ultralowdose technology, I would argue that the routine use of CBCT is viable and recommended for patients. And soon 2D radiography will be under fire for over-radiating and not 3D like it was several years back. The other question I always get is, does it change the treatment? And anybody that's used CBCT for any length of time will answer, yes, it absolutely does. What I've found, though, is that it never will change it until you begin using the technology. And when I think about this, I think back to my background in philosophy, and I think about Plato's allegory of the cave. And those of you that are familiar with it, what the situation was is you've got individuals that have been held captive in this cave, and they're only able to see what's projected on this wall. And what's projected on that wall are shadows that are created by the characters behind that wall between the flame and the prisoner or the captive. And so eventually, this is the only experience they've had with the world. It is a completely 2D world. It's all they know. And one day, one of the prisoners gets out. He escapes. He goes out to the world. He's blinded by the light. Like it's so bright. He's never been out before. He looks and he's trying to make sense of this world that's now 3D and not 2D. And he sees this tree and he's like, he looks down and he sees the shadow of the tree and he recognizes, oh, that's a tree, but it's got color and it's in 3 dimensions and it's beautiful. He's excited and he runs back to his friends. He's like, hey, you're never going to believe, we've got to get out of here. You've got to come experience what I've experienced. But the friends say, you're crazy. I'm fine where I am. You have lost your mind. That does not exist. It's not possible. Why would I ever leave? I'm comfortable. And so the question really is, are you comfortable where you are? Or maybe do you need a little discomfort to move you forward to where I would argue the specialty is going? And the reason the specialty is going there, and this is a result of a conversation that I had with several of the presenters at the AAO winter meeting, many of which were in academia. And the conversation out at dinner one night was basically around the fact that it's not a matter of if this technology will be adopted, but it's a matter of when. Part of the reason that it's a matter of when is because you can do anatomy-based orthodontics. You can look at the alveolar housing within that holds the teeth, which basically means you're able to then plan treatment and provide treatment in a way that maintains the health of that patient. Because at the end of the day, one of the very first events that we had in dental school, and I'm asking you to remember back quite a ways, was the white coat ceremony, where we basically said, we took the Hippocratic Oath and we said, we want to do no harm. And at the end of the day, that's my motivation for CBCT in my practice. It allows me to see what I need to see and hopefully use mechanics and treatment modalities that allow me to minimize the harm that I'm causing. So what are the benefits of 3D, of CBCT in orthodontics? This is from an article by Ma, and ultimately it's the 3D representation. It's the ability to reformat the image into different perspectives. No magnification error. You can look at superimpositions, which we'll talk about that shortly. The ability for diagnostics, modeling, manufacturing, and then ultimately, and this is back, I think, before really ultralowdose had come out, the radiation exposure was within the norms of other radiographic imaging. Well, now it's less than other radiographic imaging modalities. So there's certainly a vast majority of benefits to CBCT in your practice. And at the end of the day, it allows for proper diagnostics and proper treatment planning. It allows you to look at the alveolar housing, which in my practice, in my hands, dictates the treatment options and determines the treatment plan way more than a Seth or a Pan ever could. Because it's ultimately that anterior alveolar boundary that's allowing me to make the decision on how much I can either retract or procline lower incisors, whether bone is there to do so. It's looking at the posterior alveolar boundary and evaluating that prior to placing an expander or determining which type of an expander needs to be placed. It's letting me look at the biological limitations that exist because we're working on a patient that you cannot see in 2D. And it really allows you to treat that patient to their anatomy, not to these racial norms and analyses that we're used to dealing with. And it also lets you take into consideration airway in all three dimensions of space. I'm not saying you can diagnose on that, and it's a whole other story. So the key is it lets you treat to the patient's anatomy. So it's anatomy-based orthodontics. So it really is anatomy, not analysis. No longer is 2D enough in a 3D world. The world is not flat, and your images should not be flat. Limitations exist. Your patient has limitations. It's just a matter that you can't see them in 2D, and many times, if without that knowledge, you will choose mechanics that will violate their limits. With 3D, it lets you know what the limitations are prior to determining what treatment needs to be done. So a lot of people ask about 3D analyses and what I use and what's out there to use. Case Western Reserve University has a 3D analysis. Sean Carlson, who is an orthodontist in California, does quite a bit with CBCT, has developed a BCA analysis. It's really good. But at the end of the day, it's that you have the information you need to treatment plan the case properly. You've got the NPR view, you can create a pan, you can create a lateral Seth, you can create a PA Seth, you can create a segmento vertex, you can look at the boundary areas, and you can look at pretty much any other view that you want to that will help you in diagnosing and treatment planning the case. Prior to ultralowdose technology, we spent a lot of time looking at indications. If you look at this list, I would argue that vast majority, 80 to 90% of patients fall into this list anyway. The benefit that we have now is that it's less radiation than 2D. So it basically means that it's indicated in all patients, not just that you have to take a 2D image to justify your use of 3D anymore. One of the obvious areas that it can be used is maxillofacial distal morphology. I'm going to fly through this so we have time for questions at the end. Here we go. Let's look at this real quick. Is there anything wrong with this pan? I'll give you a hint here. I gave this presentation a couple weeks back to the residents at UT Memphis. If you look at the maxillary left sinus, you see something that you would say, oh, it looks like it might be hyperdensity. Maybe something's going on there. I think it's just a ghost image from the earring. There's very little of anything to point out on this pan. Here is the rendered Seth, because I did not have a Seth on this case to show you. So I rendered one. There's very little on that Seth that I think anybody would pick up on and say, hey, is there something wrong here? If you look at the MPR view in the axial and the sagittal and the coronal plane, you can see there's not only one supernumerary tooth, there's actually two supernumerary teeth in this case. And if we look at the rendered volume here, you can see that, you can see exactly where those teeth are and visualize that in a pretty amazing way. And then you try to sit there and explain that to a patient, they get it. It's not, again, it's not a pan where the extra teeth are outside of the trough and they can't be seen. And now you've tried to upright those roots, but you couldn't upright the roots. And you're saying, why can't I? Why can't I? Why can't I? I'm in a heavy wire. And then you've either A, potentially caused damage to those teeth, or B, you finally get frustrated enough and say, I got to get more imaging. And then you either send for a CBCT or some periapical radiographs. And then you realize, oh, that's why I can't upright the teeth. The problem with CBCT, many times you don't know you need it until you've already got it. So here's another case that we can look at. It's a Pinot case patient. This is the pan I got from the pediatric dentist. You look at that upper right lateral and the upper left lateral, and the upper right one, you can say, okay, I'm a little worried about that, but I think I see an outline of the distal root based on the position of the upper left lateral. You're saying, okay, it's probably just, ectopic and displaced. But when you look at the CBCT and go through the slices, and this is what I'm talking about, the ability to reorient the image in any way that you want to get the information that you need to better diagnose and better treatment plan the case. And so this is just a video of me scrolling through some of the slices, showing you just how easily you can visualize exactly what's going on with those teeth. Let's see here. So this is the day that I took the lateral incisors out and placed a TAD, took a baby canine out, and took out lower premolars. And you'll see there when I took those lateral incisors out, I took pictures of them because I was like, I just can't believe it. It was worse than what the CBCT, the radiography indicated that it would be. And you can see there on the screen just how bad the resorption was. Now, hopefully we would have said, oh, well, if I'd had 2D, if I was practicing a 2D world, I would have obviously gotten periapicals on these. And I would have realized that it was damaged, and I might have treatment planned the case, the same way. Well, you know what? I didn't have to over-radiate my patient with additional PAs that are more radiation than most CBCTs are. I was able to make those treatment decisions with the patient with just the ultralowdose image that I had. And so this is how she finished up. She's pretty happy. So here's an expansion case where CBCT was beneficial. This is I want to say he was 14 or 15 when he started treatment. And it was a case that needed expansion. He'd been to a general dentist who had offered him a particular aligner brand in order to correct his transverse discrepancy. I took a CBCT and said, I really don't like where your teeth will be if we just either were to use arch wire expansion or traditional Hyrax or even some other type of expansion technique, be it clear aligners or whatever. And so this case was placed for TSADs were placed. And the palate, sorry about this image. I know he clearly needed to clean it better. My assistant should have had him clean it prior to the photos. But you can see how much expansion we were able to get. And he's not even fully out of crossbite yet, but we've got him a long way towards that point. And then I was able to get him the rest of the way using traditional mechanics with fixed appliances. And so I want to get to the before and after. So here's his finish. And here is before expansion and after expansion. What I want you to notice is the bone that's buccal to the upper molars in the before and the after. I think had I used a traditional Hyrax, 75% of the expansion that occurs is actually due to dental tipping, and only 25% is due to bony expansion. If you use a skeletally fixated expander, I think it's the opposite. I want to say it's like 75% is due to bony expansion, 25% is due to dental tipping, and I think that's in large part due to the alveolar housing actually tipping out when you're pushing, because the greatest source of resistance is the infrazygomatic process. So that's another great case where the CBCT helped me determine what type of expander I needed to use, because I was able to look at the mid-palatal suture, I was able to look at the bone and buccal molars and determine, hey, I need something a little bit heftier than just a traditional expander, and certainly heftier than some sort of aligner solution. So alveolar boundary conditions, it is the main reason that I would say every orthodontist needs to adopt CBCT technology in their practice, and it ultimately will be the reason that we all adopt it, because we actually see what we need to see in order to make the treatment decisions we need to make on whether we can flare teeth, tip teeth, or treat with what appliance we need to treat with. So here's just some slices through this. You can see how thin that alveolar bone can be, and the festooning within the bone, not even looking at the gingiva, but within the bone that's present there. And then this is a video showing you just just what that looks like in a 3D rendering, which I'm going to skip so we have more time for questions. So another great way that CBCT helps us, it allows us to continuously improve. John Price is another great friend of mine that said the best way for you to improve as an orthodontist, Jay, is to look at your records and be critical of your own treatment, and the ability to superimpose in 3D versus just trying to superimpose Seth tracings, which can be incredibly inaccurate, and easily you can kind of bluff a little bit on those, but it really forces you to be honest with yourself, because you're superimposing in 3 dimensions of space and able to get a very accurate depiction of what the effect is of the treatment mechanics that you've used. So CBCT is very helpful for that. Here's a short little video showing just how easy it is to do that. You superimpose over anterior cranial base, and then you just look at the treatment, and you can see what you did in all 3 planes of space. Pretty cool technology. And one of the ways that I see this technology being used, and I'm really excited about how it's being used, is with a company called OrthoScience. And if you're unfamiliar with that, you really should take time in the next, we've got the time now, to find out more about it. It's Polaris is the orthodontic platform on it, and it was put together by Sean Carlson and Abby, and basically it allows you to look at other orthodontists' work, and that work is verified by OrthoScience to determine whether or not, or what was actually done in the treatment plan and the timing of that. So no longer can somebody stand on stage and say, oh, I finished this in 24 months, when if you looked in the chart note, it was actually 36 months. It's verified information, and you can see you put your own diagnosis in, and after you put in your diagnosis, you can see what other orthodontists have diagnosed it as and how they would treatment plan the case. And then you get to see the results of the case, and you can look at that information in all 3 planes of space and basically get a chance to put your toe in the water when it comes to 3D technology, even if you don't have the technology in your practice. I think this is of great value to our profession. And strongly encourage you, if you haven't had a chance to take a look at it, to do so. I have no financial interest in that. I am on the advisory board, but that is it. What is the take-home message regarding CBCT? Well, it's what you can do with the technology that's so important. It's the ability to properly diagnose and to treatment plan the case. It's the ability to look at the alveolar housing, which I would say ultimately dictates your treatment options and determines your treatment plan. It really makes it more about the patient's individual anatomy and not so much about historical norms that we were used to looking at. So there's no more guessing, there's no more missing. And in addition to all those benefits, there's less radiation and significantly more information so that you can treat your patients to a higher standard of care. So it allows you to differentiate your practice and yourself in a 3D, in a DIY world. And so today we've talked about the benefits of 3D. We've looked at differentiation. We've talked about ultra-low dose and its value, and I can't stress that enough. We've talked about anatomy and not analysis, an individual patient's anatomy, not so much historical norms, and then the ability for you as a clinician to improve yourself, I think is huge. So with that, we will wrap things up and take a few questions.
All right. Thank you so much, Dr. Burton. Again, if you have questions, please submit them in the Q&A area. We have quite a few, so I'm not sure how we'll get through, but we'll give it a shot. So somebody asked what the first year that ULD was available, and how do we compare that to our current 3D, and is it worth the upgrade for a change in radiation? And I just confirmed that ULD was introduced from Plan Mecca in 2014, but maybe you could speak to the changes in radiation.
You know, I think that's going to have to be a personal decision for that orthodontist. For me, my practice is made up of about 75% kids, and so radiation dose is very important. If I had a practice where I was treating 80% adults, maybe I would be less inclined to say you should think about upgrading. But I think it depends a lot on your patient population. Would be my answer. And if you were treating a whole lot of kids, that would incline me to adopt ultra-low dose technology. Chances are you've already, depreciated the machine anyway. You could use the tax write-off, so why not?
All right. A couple questions about which software you're using to manipulate your images.
So I use Romexis, Plan Mecca makes the machine that I use, the ProMax Mid, and Romexis is their imaging package that comes along with that. So there really isn't any additional software. I think they actually upgrade the version that you're on for free until they go to, like, if they're at a 4.5 to 4.6 to 4.8, those upgrades are all free. And then it's just a minimal charge when you upgrade to like 5 or you upgrade to like 6. So I just use Romexis. Let me rephrase, for 3D imaging. Now, for 2D imaging, I currently use QuickSeth.
Great. A couple questions about how you're charging for CBCTs and how you make up the difference in costs.
So for me, what I did is I referred out my CBCT imaging to an oral surgeon until the point that I was referring out enough patients every month to make a payment on a machine, which it doesn't take long. The average orthodontist is seeing about 20 starts a month. If you just increase your either your records fee or your overall fee by $100, which isn't that significant, the patients aren't even going to notice it, you're going to easily pay for the cost of the machine. So there are some companies out there that do some medical billing for orthodontists that deal with that kind of thing. I just have not gotten involved in it. Unless it's a trauma-related case, then there's a company that I work with. It's Crystal May's company, Jody. I don't know. I can't remember the name of it.
DevDent?
DevDent. That if you want to bill medical, then you can look into that. And I do that on trauma cases because once trauma has been noted in their medical history and paid for by an insurance company, then all future needs can then be covered by medical insurance if anything else were to happen. So it's not so much for my practice and getting the money from medical billing. It's really more for the patient's benefit to say, hey, if anything happens in the future associated with this tooth, then it's going to be covered under your medical insurance if it was covered under medical insurance in the first place.
Got it. How and why does Plan Mecca have advantages over alternative CBCT systems in the marketplace, offer comparative reasons, values, and why you ultimately chose Plan Mecca?
So, and I'm glad that question was asked because I want to say this. I bought the CBCT machine long before I ever spoke or did anything related to Plan Mecca. And the reason I did is when I did the research from a cost perspective, it was a no-brainer, the 5-year cost. and then you look at image quality of their ultra low dose image compared to the other machines on the market, and there is a significant difference. And I would just encourage you to make sure when you're talking to the sales reps of these companies, tell them you want to see the images at the lowest radiation dose possible, because what some other companies have not done is put the R&D in the algorithms necessary to get diagnostic images from low doses of radiation. The reason I had the paper from Ludlow and Coivisto, or the poster, was because at the end of that, and it was the statement that said they were able to maintain diagnostic image quality while reducing radiation dose. If you go and look at some of the research that Ludlow's also done on other machines that are out there, you don't see the same statement. You see statements like they were able to reduce the radiation dose, but it had a significant degradation on the image quality as a result. And maybe it's not that straightforward because nobody wants to talk negatively about anybody or anything, but that's really what it says, if you're reading between the lines. And Plan Mecca, it wasn't said, and if anything, it was said that they maintained image quality even with the dose reduction. So that's why I wound up buying the ProMax Mid.
Great. And we're coming up to our time right now. We actually had several people ask about CBCT education courses, and Plan Mecca will be offering later this year a 2-day CBCT interpretation course specifically for orthodontists. But because of our current situation and people not necessarily wanting to travel in the near term, we will be offering an online 4-hour course, again, specifically for orthodontists in June. If you are interested in getting information on that, please contact me into the chat or Q&A function, and we'll make sure that you get that information sent next week when the registration is available. All right. Any parting thoughts, Dr. Burton, as we come upon our time?
No, I'm honestly really excited about where our profession is headed. And it's because of CBC technology and the capabilities that it gives us to better treat our patients.
Great. Thank you so much. Thanks, everybody, for joining. And for those of you who reached out with questions, I'm sorry we didn't have time to answer them all. But again, if you are interested in more information or joining our CBCT interpretation course for orthodontists, please contact me in the chat. Thank you so much, Dr. Burton. Everybody have a nice Sunday.
Thank you.